Hello, my name is Virginia Kaklamani from UT Health. I have the honor and pleasure to have Dr. Jack Cuzick with me, our McGuire Awardee for this year. Dr. Cuzick, you've worked a lot in prevention.
Yeah, we started almost 40 years ago now, actually, and the first publication was in 1985, in which we made the sort of seminal observation that, in fact, not only that breast cancer is unique in the sense that you've got two breasts, and if you give a drug for treatment in one breast, you could observe the effect of prevention in the other breast. And we saw that 45 years ago.
5 years ago. Yeah. And since then, a lot of the trials have generated data on both tamoxifen and aromatase inhibitors in prevention. But those trials have really shown prevention in ER-positive breast cancer.
I think that's probably going to be the case, actually. I think that we're talking about something that stops ER-positive breast cancer. But nevertheless, that's 70% of breast cancer. And I think, it does say that if we could get rid of that, then we could focus our efforts on what to do about ER negative, because that's the fatal one, basically, more often. Yeah.
And you spoke about fatal one, and when we look at the updates from these trials, we've never seen a survival benefit. Now, you talked a little bit about this during your McGuire talk, but what is your feeling about survival in chemo prevention studies? Because obviously you're preventing ER-positive breast cancers, but this really helping women live longer.
Well, the challenge with prevention in general is it is a very long-term game, and in particular if you're interested in survival. Typically a patient, once they get breast cancer, they'll survive for 10 years if they're ER-positive. So it's, believe it or not, it's too early to say. We've actually shown that tamoxifen does influence survival in the adjuvant setting. Mm-hmm. So I suspect that the same is going to be true in the prevention setting, but it's going to take longer now. We've got, we just published stuff fairly recently, but it was on older data, and we're sort of 7 years out of date in terms of the cases. So we're going to do that in the next year or so. We're having trouble with the NHS and the UK to get them to be able to flag the patients. They flagged them before. It's just bureaucratic chaos, to be honest. But there's a lot of that about. Anyway, so I feel comfortable that we will probably fight it, but it's going to take a long time.
And when we talk about high-risk patients, obviously you've developed the Cuzick model that we use all the time in clinic, but who really, in your mind, regardless of studies and regardless of the Gale model that was used, who really is a candidate for chemo prevention?
Who's a candidate? We've used, we believe that 10-year risk is a better marker than 5-year risk, like the Gale model used. And our baseline is that if your 10-year risk is more than 5%, you should consider chemo prevention. If it's more than 8%, you should be strongly encouraged to do something, to take it.
And would that 10-year risk be with the Cuzick model or because the Gale model is going to give you lifetime and 5-year risk?
Yeah, no, we use our own model. We think it's better.
And do you take into account breast density?
Absolutely. Yeah, the version 8, which is the one we're on now, puts in both breast density and a SNP score. So we look at a whole range of SNPs as well.
That's exciting. And as far
as... They both matter. They really both matter.
They do,
They both, yeah.
And if you look at the next 20 years, because as you said, prevention is not a 2 or 5 year story, how do you envision prevention playing out?
Well, I think the first thing that really has to be done is we've got to catch up with cardiologists, and we've got to realize that preventing disease is really part of the whole process. You don't wait for somebody to get disease and then try to treat it. If you can stop it from happening, that's a much bigger win. And so the way to do that is to develop risk-adapted screening, so that a woman, particularly when she comes for her first screen at 40 or 45, whatever it is, should get, it's just a simple blood test. It doesn't take long or it's a questionnaire. You don't even do a blood test if you don't need to, unless you're going to do the SNPs. But just a mammogram and a 15-minute questionnaire is enough to tell you quite a lot. And then if you're on the margin, it's worthwhile to do the SNPs as well.
Oh. Well, I'm a firm believer that the only way to cure breast cancer is preventing it. So I'm hoping we get there someday. Soon.
And the other thing that's going to become clear is that ER-positive, ER-negative breast cancers are going to be quite different in how you manage them.
Yeah. Well, thank you for being here.
Pleasure.
Thanks to the audience for listening in, and we'll see you next time.
Thank you.